Hi, this is my case presentation and skills demonstration. To begin, we will start with some background on the client. Maria, whose name has been changed for confidentiality, is a 50-year-old Mexican American woman. She was born in America just 2 years after her parents immigrated from Mexico, and she grew up in a very impoverished and rather dangerous neighborhood in San Diego with her siblings and parents. She hasn't spoken to any of these family members in over 10 years. Maria also spent 8 months in jail due to a charge, which is why she was referred to our mental and behavioral health reentry program that helps people with co occurring serious mental illness and substance use disorder, or SUD. She has complex trauma, which stems from her childhood. Her father, who was physically and verbally abusive, had alcohol use disorder. In addition, from the age of 13 to 15 years old, Maria was molested by an adult she initially felt she could trust, which was very traumatic for her. To understand Maria a bit more, it is important to discuss biopsychosocial spiritual factors. So, biologically, Maria is obviously predisposed to SUD due to her father's SUD. She's also had hepatitis C before going through treatment to cure it, but her relapses, which involve IV use of both heroin and fentanyl, put her at a very great risk of overdose and infections. And then psychologically, Maria has a diagnosis of schizoaffective disorder, depressive type. Her symptoms began around 26 years old when she was diagnosed with schizophrenia, but 3 years ago, this was changed to schizoaffective disorder. She also has opioid use disorder, considered severe, and until now, which I will further discuss, she was considered in early remission. She also has PTSD, or post traumatic stress disorder, due to the trauma she's been through. She struggles with motivational and self esteem issues and often blames herself for her behaviors and relapses. Socially, Maria is very shy. She has difficulty making friends, although she does have one close friend with long term recovery from SUD. And then spiritually, Maria was raised Catholic but is now Protestant. She doesn't feel connected to God currently, but she wishes to in the future. So, for potential barriers for engaging in the proposed evidence based treatment plan I'll discuss, Maria's triggers of loneliness and stress often lead to relapse. She has a pattern of relapsing every 2 to 3 months typically, and it can be very difficult to engage with her when she's using since it's hard to get a hold of her, and treatment can simply not be effective if she's using. This is a big barrier. And then in addition, she experiences negative symptoms of schizoaffective disorder. So while she does take antipsychotics, they often only help with the positive symptoms, but not with negative ones like depression and lack of motivation, which she struggles with and pose motivational barriers for engaging in this treatment plan. However, Maria does have strengths which can help her engage and recover. She has a strong desire to achieve long-term recovery. She's very resilient, often quickly seeking help from our team after she faces, struggles or relapses. She also helps other clients by providing advice and stepping out of her shy comfort zone. She's curious, she asks questions in group therapy a lot, and overall, she's just very kind-hearted and generous. She's also medication adherent, especially when she's clean and sober, and sometimes even when she has relapsed. So here is the client behavior and ultimately the problem that will be focused on for the evidence-based practice. So, due to her difficulty making meaningful friendships, her isolation patterns, she often turns to substances to socialize with others. She also often relapses to numb pain or detach from depression or intense flashbacks from PTSD. Currently, right now, the problem is that Maria has experienced a short relapse on fentanyl after 3 months of recovery, but did seek help from our team rather quickly. So, to explain how I use the evidence based practice, I want to first describe dialectical behavioral therapy, or DBT. So, DBT is currently used for many different diagnoses and behavioral issues. The term dialectical means opposing goals of change and acceptance, where the client is guided to and actively practices changing behavior while simultaneously accepting things they can't change, such as the fact that sometimes distress is inevitable. There are four main components of DBT, which are mindfulness, interpersonal effectiveness, emotional regulation, and distress tolerance, all which are very useful skills for Maria. So it's very important to note that DBT clinicians should have a a really strong therapeutic alliance to create this trusting bond and relationship with clients. They're supposed to be very non-judgmental, supporting change. Since this is a pretty intense modality, it would also be helpful for Maria to commit to a 12-month DBT individual therapy plan with DBT's flexibility allowing for a specific tailoring to her needs. For this exercise, we'll use the behavioral technique of chain analysis. So chain analysis helps clients to see the chain of events that led to a behavior, in Maria's case, the relapse, the consequences of the behavior, why and how these behaviors are difficult to change, and skills to change the behavior to develop plans for preventing the behavior from happening again. There are 8 main steps of behavioral chain analysis, which you'll see demonstrated. So first, Maria is going to describe the problem behavior. She'll describe the prompting event that started the behavior, the vulnerability factors that happened before the event that made her vulnerable to relapsing. She'll describe, as DBT's creator Marsha Linehan puts it in excruciating detail, the chain of events that led to the behavior, consequences of it, and skillful behaviors to replace the problem links in this chain. We're going to develop prevention plans for Maria to reduce vulnerability. And although it's not applicable in this case, the 8th step is repairing important consequences of the problem behavior. Here are my references. And here is the video. It's great to see you again. How are you doing?
Well, I feel really crappy, tired. I shouldn't have relapsed.
I'm so sorry to hear that you went through this relapse. I'm very happy though that you reached out for help so quickly. Why is that?
Got like sick and was really close to an overdose. My friend had to Narcan me.
It sounds like you felt the consequences. So why don't we talk about what happened before and after the relapse?
Okay, it's honestly tough for me to talk about a lot of this. I don't know if I want to do it.
I totally understand. I'm going to walk you through this, and I want to emphasize there's no judgment for me at all. I'm just trying to help you understand your behavior to prevent it. Does that help?
I think so.
Okay, I'll be here every step of the way. Do you remember this chain of analysis for behavior?
Yeah, it's kind of long. God, I'm just so tired all the time.
Well, I know it can feel like a lot. This time we'll do it together so we can ease into it, and I'll be writing it out as we go through.
Okay, sounds good. Let's try it, I guess.
I'm happy you're willing. What is the behavior we're looking to change?
Using, relapsing.
What led to the relapse?
I was sick of feeling depressed and lonely. I've been in my room for a few days. It just felt like a craving.
Okay, great self-awareness. What were the thoughts going through your mind before you used?
I don't want to feel this way. I want to be with other people. I went into autopilot mode.
And how did you feel preceding the relapse?
I felt like sad, lonely, a little angry, anxious.
What changes in your body occurred?
I felt this super strong tightness in my chest.
I see. This all sounds so intense for you. How did you positively feel right after, though, after the relapse?
A relief, numbing myself.
I see. Yeah. Yeah. What environment were you in that made you vulnerable to relapsing?
Being alone in my apartment. Um, Maybe how I can still get a hold of my dealer. You know, I really don't want to die. Relapsing was just stupid.
It's good you recognize you want to live, and it sounds like you also feel some shame, but you did seek help quickly.
Yeah, I guess so.
You're doing really good, and I want to just ask, how did the relapse affect your relationships?
Well, I have to tell Andrea that I relapsed. I know she would understand since she's in recovery, but I still feel really guilty.
So you feel it may affect your relationship with her, but she'll understand. But what caused you to relapse were feelings of loneliness, sadness, isolation, having close contact with your dealer, numbing pain. Did I get all that right?
Mhm.
Okay. What skills may be useful for the next time you have these thoughts and feelings?
Calling you, calling Andrea, doing the 5 senses exercise, um, using a distraction. I could have left my house and exercised in the park. Oh, to go to a meeting, of course. That would have helped.
Okay, good, good. And how might you be able to increase the motivational struggles you have to take these action steps?
Well, when I'm going to meetings every day, it feels more normal. Like I'm used to it. And just reminding myself that Andrea is understanding helps me feel more motivated.
Great. So based on what you've done in the past, what other things can we add to create this prevention plan?
Going to the park to walk or jog, I can block my dealer's number. I just like need to do it.
That is important. Good, good. Now I have a prevention plan for you. So deleting and blocking your dealer's number, great. Calling helpful people like Andrea, going to meetings every day to increase your motivation, doing some exercise at the park, the five senses exercise. How does that all sound?
Good. All good stuff.
I'm glad to hear it. You've done a really good job. I'm so proud of you.
Thank you. I think this has really helped.
Of course.